Dr. Kirkwood. Morning, everybody. Let me share my screen. All right, so as Dr. Kirkwood said, my name's Amy Rose. I'm the Clinical Research Manager for the Melanoma Center. I've been working in the Melanoma Center for a little bit over 12 years now. And I'm going to talk today about what to expect on a clinical trial. So first of all, what is a clinical trial? Clinical trials are research studies that are performed in humans to evaluate new medical techniques. Typically, these are, in our case, we use a lot of different drugs, new drugs, sometimes first-in-human drugs as well. But they can be, in other centers, maybe a surgical device or any different type of even biobehavioral as well. Clinical trials are used to find safety, tolerability, and optimal doses of new drugs and combinations of previously approved medications. So even with melanoma and all of the standard of care medications we have available, sometimes that isn't enough for us. We still want to see more patients responding and to have less side effects. So a lot of times we're continuing to develop new drugs that may benefit patients a lot more. With those drugs, a lot of times, especially the first-in-human drugs, we need to start at a very low dose and then work our way up to what's called the maximum tolerated dose. And sometimes we do combinations of whether it's a new drug with, for instance, one of the PD-1 drugs like pembrolizumab or nivolumab, just to see if we can get any type of better responses. But again, looking at the toxicity that's involved too. We don't want the drugs to cause more harm than what they would standard of care. So I'm going to talk about some parts of a clinical trial. Some of the very basic ones. Number one is informed consent, the screening evaluation, and then on-study or active treatment, and then the follow-up as well. So what is informed consent? It's an ongoing process to educate participants on the treatments, logistics of the trial, the risks and benefits of trial participation, and any financial responsibilities that you have. So what typically happens, the physician will come into the room as well as the clinical research coordinator, as we call them, the CRCs, and they will review the consent with you. They'll bring in a paper document for you to review. Inside the consent is every single side effect that has ever happened to anybody on one of the trials. And it can be anywhere from, a cough to even as severe as death. But anytime anybody does have any of the side effects that the physician thinks is possibly related to the clinical trial or the study drug, it has to be listed in the consent as a possibility. So typically the doctor and the coordinator will come in, they review the consent with you. We want to make sure that all of your questions are answered and that you know every detail about the trial, everything from how many times you're going to be here on the campus, or if there's biopsies that are involved or any research bloods that are involved. All of that is important information for you to know. And please don't hesitate to ask any type of question that you might have. No question is a stupid question, and we'll absolutely answer it for you. And if we don't know the answer, we'll go to the doctors to find out for you. But after a thorough review of the consent, and you can take the consent home to review as well if you want to review it with your family or another physician, that's absolutely fine. And then you can just give us a call and we'll be able to sign the consent then. But after reviewing the consent, you want to sign and date the consent. Sometimes there'll be a time as well. And then the physician will do the same thing. You will receive a copy of the consent document, as well as there will be a copy in your medical record. So next is, what is the screening process? So every patient going on to any clinical trial has to meet certain criteria. So all potential participants must meet all inclusion criteria and none of the exclusion criteria. These are different for every single trial. You might not be eligible for one trial, but there is another one that has a different set of criteria that we might be able to get you onto. So again, it really depends on which clinical trial we're looking at. A lot of times there will be additional tests. Most of these tests include scans, whether CT scans, MRIs, We will do a physical exam with your physician or the PA. Lab work, sometimes we do EKGs, echoes, pulmonary functions test, and it seems like a lot of testing, and sometimes it does take some time to get all of these scheduled, but that's just to ensure the safety of the participant. We want to make sure before we give these drugs that you know, you're healthy enough and it's safe enough to deliver the drugs for you. We also review your past medical history. Sometimes trials want us to look back as much as 10 years to make sure that there's nothing in there that would exclude you. For instance, if you have congestive heart failure, there's certain grades that may not be allowed on a clinical trial. And then we review all of your medications. Again, current medications, typically it's within the last 30 days that you've taken. These include both prescriptions and over-the-counter. And again, we also review with a pharmacist to make sure that any of the medications you are taking aren't going to interfere with the study drug as well. So that's something, you know, we work with the pharmacist to make sure that that's safe as well. After all of the test results are done from the screening process, they are reviewed by the clinical research coordinator to make sure that all eligibility is met. So the clinical research coordinator does what we call the first check. Either myself or somebody from our quality assurance team will do what's called the second check, and it's just another set of eyes to make sure that we have all the supporting documentation to prove why you are eligible for the trial. And then we have the third check by the physician, where the physician will review and then sign off as well. So what is on study? So once eligibility is confirmed, the participant may begin treatment. If it is a randomized trial, we do have to send the information to either the sponsor or into the database. And that way, randomized just means that it's the computer will pretty much choose which trial treatment you will be on. Not all trials are randomized. Sometimes they are just a single arm, meaning everybody gets the same study drug. But once all of that is confirmed is when you can actually begin the treatment. The protocol will mandate what happens at each treatment visit, but very typically you'll come in, and I know Darcy talked about this a little bit as well, you'll come in, you'll have your vital signs done, you'll have your lab work drawn, you'll be seen by either the PA or the physician. There are typically a lot of research labs that are involved, so those will be drawn sometimes before your treatment, sometimes after, and for up to a couple hours after as well. And again, your research coordinator will discuss how long you should anticipate your visit will be that day. Your CRC will also meet with you at every single visit that you come in. They will discuss any side effects you might have or any new medications. But I do want to emphasize, if you are having a side effect, you do not need to wait until your next appointment. You can definitely give us a call beforehand so we can help take care of those side effects for you. And again, any new medications you might have, if you go to your PCP with a cold and they give you maybe an antibiotic or something, you do want to call us before taking that just to make sure that it's not going to interfere with the study drug at all. And even any over-the-counter medications, especially if you're taking any kind of supplements or some of the herbal medications, you definitely want to talk to your clinical research coordinator before starting any of those. So some of the possible clinical trial events at each visit, again, it's different and laid out based on the protocol, but very typically you'll see research bloods. We will draw different types, either PKs, PBMCs, and what we're doing is just seeing how much of the blood is in your body at a certain time point after taking it. Another thing that we do a lot is the biopsies. The biopsies are very common and it's very helpful for the research to continue. The biopsies are typically done at screening or baseline prior to starting the medication. Sometimes we can use what's called archival tissue, where if you had a surgery or biopsy previously, we would be able to use that if it's within a certain amount of time. But a lot of the biopsies are what we call fresh biopsies, and we would need new biopsies as well. And then we have what's called the on-study biopsies, and they typically happen after a certain amount of time of being on the clinical trial. And what we're looking for is to see what's happening to the actual tumor itself while giving you these new medications. We do a lot of EKGs. Sometimes we do what's called triplicate EKGs, where at each time point we take 3 EKGs, so many minutes apart, and that's to get an average of what's called the QTC for your heart rate. And it's, again, for your safety to make sure that there's no cardiac toxicity going on, or any underlying cardiac issues that might be developing. There are questionnaires that are involved where the participants will fill out the questionnaires. A lot of these questionnaires are related to your quality of life. There are some dietary questionnaires as well. But the questionnaires are really, again, to see, while giving you this treatment, are you still able to maintain all of your activities of daily living and, do the things that you enjoy, or are we hindering your quality of life as well? So that's very important for us as well. The dietary questionnaires, I know some of you may have participated in some of those. They can be very lengthy. And I know I don't always remember what I ate for breakfast yesterday, but sometimes it's good if your coordinator will discuss with you if you're doing the dietary questionnaires, maybe to keep a quick journal or something as well. And then we do have other specimen samples. Quite often we are looking at whether it's saliva specimens, sometimes stool specimens. And again, your coordinator will let you know when you need to bring those samples into us, or when we'll have to have them provided as well for your visits. So the next part of the clinical trial is follow-up. And this occurs after treatment is complete or if it's no longer working. So a lot of the protocols will mandate treatment might happen for maybe 1 year, sometimes 2 years, or sometimes it's an indefinite amount of time. And we continue on the treatment. As we like to say, we like to ride the wave as long as possible. So if the treatment is continuing to work, you would continue to receive treatment. However, if for some reason the trial treatment is not working, we would stop and discuss with the physician about moving on to a different trial. But even though you may not be receiving treatment, we still have the follow-up procedures that happen. So the first follow-up visit is called a safety follow-up visit, and this usually occurs about 30 days after your last dose of drug. And again, it's mandated by the protocol, but sometimes they will include scans, some lab work, physical exam, EKGs, and again, a lot of research labs as well. Next, we have what's called long-term follow-up. Again, you're still part of the clinical trial. If, for instance, if the treatment is complete, a lot of patients will move into long-term follow-up, and these usually occur every 3 to 6 months, depending on what the protocol mandates. And these typically include scans just to make sure that you're still responding and haven't progressed at all, as well as lab work and a physical exam with either the physician or the PA. And then the next part of survival is called the the survival follow-up visit. This typically occurs every 3 months. You may not be receiving treatment on the trial anymore, or you might have moved on to a different treatment, but we still continue to follow up to see what treatments you are receiving and just how you're responding to those and how well you're doing on those as well. This does not typically need to be an in-person visit with the physicians or the PA. A lot of this can be done either over the phone or actually just a review of your medical records as well. So some benefits of participating in a clinical trial. Number one is access to novel treatment approaches. These are drugs that are only available through clinical trials and are not yet approved by the FDA. So they definitely are only available, like I said, through a clinical trial after the consent process is reviewed and all questions are answered. Another benefit is the close monitoring by the clinical research team. You will, like I said, you'll see the CRC every visit as well as the doctor and the PA. You can call your coordinator at any time if you have any questions or if you're having any type of side effects at all. You can absolutely call them. You can call myself as well if you can't get a hold of them. And they will typically get back to you, within a couple of hours. Some of the treatments on the clinical trials are free or at low cost. Because a lot of the drugs are not FDA approved, there's the sponsors or grants may provide those drugs to the participant as well. So that is another thing. A lot of these drugs, if you're doing them standard of care, can be very costly. So participating in a clinical trial can eliminate that. And the biggest thing also is contributing to research may save lives in the future. Even though the clinical trial might not work for you, we do learn so much from even somebody, you know, that unfortunately didn't have a great of a response as we hoped. There's still so much to learn from the research bloods and the tumor tissue and even the responses to improve additional clinical trials in the future. So we review the benefits, but there are some risks as well participating in clinical trial. And one being that there's potential side effects and possibly unknown side effects that we may occur. So for instance, especially a lot of the first in human drugs, these drugs haven't been out for a long time, so we don't know the long-term effects of them either. And that's something, again, with additional research that we do learn. But you know, there might be other side effects that aren't listed in the consent that you may experience. And again, we need to know about those as quickly as possible, so that not only can we obviously help you with your side effect, but alert other patients to the possibility of this side effect as well. There may be more frequent tests or doctor's visits. And again, this is mostly for your safety. There might be additional, you know, echoes or even scans and stuff that may occur that wouldn't be typical part of your standard of care treatment. And again, it might seem like you're in to see the doctors a lot. But again, it's again for your safety, just to make sure that you are, you know, doing okay on the treatments and nothing is hurting you more. Another risk is that the new treatments may not work. You know, we hope that they are better than the standard of care, and there's a lot of research and time in the lab that happens before these drugs get to the human population, but sometimes, unfortunately, they don't work, and that is one of the risks of the clinical trial as well. And another one is that insurances may not cover all costs. This used to happen a lot, but doesn't happen as much anymore, where the some insurance companies, for instance, have a clause that say you're not allowed to participate in a clinical trial. We have a insurance verification process that all patients have to go through before participating. And you will receive a call from our financial counselors that will alert you if there are any insurance issues or if there's any kind of cost that may be associated with it. So that has to happen before you start on the trial as well. So this is a picture of our team for the melanoma clinical trial team. As you can see, there are a lot of people that are involved in the clinical trials. We do have a lot of patients on clinical trials, and it does take a lot of work and a lot of teamwork to make sure everybody's safely and effectively treated. So your team members include, number one is the clinical team. So that is your physicians, the PAs, and the collaborative practice nurses. They'll see you at visits as well and play a very essential role in being part of the clinical trial as well. There's myself, the clinical research manager. My job is to, number one, make sure that all patients are treated as appropriately as possible on the protocol, as well as open any new trials and to bring any trials in that we think we might be able to accrue more patients to, or you know, that might be good options for patients as well. Next, you've heard me talk a lot about the clinical research coordinators. They're on the front line. You will see them, like I said, at every visit. We do have right now 6 clinical research coordinators. You're typically assigned to one. You might see if somebody's off a day or what have you. You might see some of the other ones. Or if you go from one clinical trial to another one, you might meet quite a few of them as well. Next is our research assistants, and they do a lot of the behind the scenes kind of work. Their biggest job is, number one is the data entry. So all of the information that their research coordinators bring back to the research assistants, they are entering into databases, and that's the data that's used to hopefully grant FDA approval in the future. So that's very important work, and there's a lot of just a lot of queries back and forth between the physicians and the RAs, or the study sponsor and the RAs as well, just to make sure that the data is accurate and that we have provided a source to back up and prove that the data is accurate as well. The research assistants, you may see them at the biopsies. They are there to help pick up any biopsies and deliver them to what labs they need to go to, as well as your research lab kits. They are in charge of prepping the lab kits to make sure that we have the right number of tubes for the right tests that we're going to perform as well. And then we also have our regulatory specialist. So they work with the IRB, which is the Institutional Review Board. The IRB's job is to make sure that the team is practicing and according to the protocol, and to make sure that it is safe for the participants as well. So the regulatory specialists work very closely with the IRB and the study sponsors to make sure that we have the most up-to-date information in our consents, make sure any changes to the protocol happen very quickly so that we can get that information out to the participants as well. So some of the trials we have here at the Hillman Cancer Center, specifically for melanoma, number one is our banking study, 9699. This is a cornerstone for all of our clinical trials. Almost every patient that walks through the door, we are going to ask them, to participate in this. We do draw research bloods, up to 14 tubes of research bloods, and those bloods are stored in Dr. Kirkwood's lab. We can use them for future research and for research related to that participant as well. We can also bank tumor tissue, whether if you're having a biopsy, we may ask for an additional core or additional part of the biopsy to be banked as well, again, for research. And there is other specimens, pretty much any bodily fluid that you can think of, we are able to bank. If there's a need that would arise for additional research on it, we may go back and ask again for additional bloods or specimens as well. Next, we do have adjuvant treatments. So adjuvant treatment occurs after a patient has had surgery and is rendered disease-free. We have typically, right now, we have adjuvant treatments available for stage 2 melanomas, where in the past there is not an adjuvant treatment approved for a stage 2. So we do have a couple of those right now. And again, that's to prevent the recurrence of the melanoma from coming back. We also have neoadjuvant treatments, and this similar to adjuvant. However, there is a period of usually of a couple weeks to maybe a couple months up front before having surgery that you will have a treatment. And then after your first, what we call like the prime phase of the treatment, you'll go to have your surgery, all the cancer is removed, and then we continue treatment afterwards, and again, to prevent any recurrences that happen. We do have clinical trials for frontline treatment of advanced disease. And frontline just means that you have not received a treatment in the advanced or metastatic setting yet. And then we also have targeted therapy for advanced disease. Again, Melissa went through a lot of the BRAF MEK inhibitors, but these are based off of any mutations that we may find in the tumor itself. And then we also have treatment for refractory disease. And what that means is just unfortunately, if you don't have as good of a response as we would like for your frontline treatment, we do have refractory treatments as well. So our job is to try and open up as many clinical trials as possible to make sure that we have, a lot of different options until we find the right one that works for you. We also I did want to touch base on like different types of clinical trials. One being the sponsored trials where drug companies, whether it be BMS or Merck, or even some of the smaller drug companies, are providing and supporting the research for the clinical trial. Another one is called cooperative groups. And these are done at academic institutions throughout the country. Typically, these are phase 2 and phase 3 trials because we need a large amount of patients for those trials. And for instance, if we opened it here in Pittsburgh, we wouldn't have as much of the population as we needed. So these are academic institutions across the country that participate, and then all the data is together in the cooperative group and to work through. And then the last type of trial we do is what's called an investigator-initiated trial. These ones are definitely my favorite. They're the kind of like homegrown trials in Pittsburgh. The doctors will write the trial after a lot of research that happens in the lab. These may be grant funded, or there might be some drug companies may sponsor part of it, whether supplying the drug or providing money for the correlatives, the research samples that happen as well. So I did want to just list out, because of clinical trials, these are all of the drugs that are approved through the FDA for standard of care melanoma. As you can see, there was quite a few that are approved. In fact, we had some, when I started 12 years ago, there was only IL-2, dacarbazine, and interferon. And since then, we have worked on a clinical trial for every single one of these drugs, and that now are FDA approved. So that's all because of the clinical trials and the participants that participated in the trials that led us to all of this drugs that are available for patients' standard of care. And then I just wanted to conclude by saying thank you. It's a huge thank you to all of the patients that have participated in clinical trials. Without you and without your participation, none of this would have been possible.